And I think a lot of people are facing other challenges during this time. You would think it's a happy time. I think it's going to be a little bit more challenging for a lot of people this year. And we are here, Anne and I, to try to help you mitigate some of the challenges you may have, especially going into new healthcare years, and you may be trying to get prior authorizations or your insurance have changed. And there could be a lot of challenges with prior authorizations that's becoming more and more difficult. Um, so Anne is living it. Anne is a myeloma patient, has been since August 2022, and she has gone through her experience with prior authorization. I think what she's going to share with you is invaluable. And I appreciate it if everyone would take notes because a lot of the points she's going to give you are very, very important. If you have Medicare Advantage, a lot of you may have already experienced some of the challenges with our prior authorizations. After she goes through the prior authorizations and great points to help you overcome some of those things, I am going to be going over medical denials and points to help overcome medical denials, get bills paid. So right now, I'm going to turn it over to Anne. She's going to share with you her background. And I think you're going to find this very interesting. And then we'll come back and go through the medical appeals.
Thanks, Diane. Can you all hear me?
We can hear you.
Not unmuted? Okay, good. Thought I unmuted myself. Want to make sure. As Diana said, I was diagnosed in August 2022, and I was diagnosed with stage 3 high risk IgG kappa multiple myeloma, along with secondary AL amyloidosis. And diagnosis I had from between 50 and 100 bone lesions. I think the radiologist just quit counting after he hit 50. It's such a large range. The diagnosis was picked up during my annual physical, and I had absolutely no symptoms. My PCP just happened to do a urinalysis, and it showed elevated protein. She had me come back the next day. She said, "You're playing tennis, you might have been dehydrated." So I went back the next day, same result. And so the third day, she said immediately, "Let's do a 24-hour urine sample." And with those results, I was immediately referred to a myeloma specialist at the local regional cancer center. My induction therapy included the 4-drug regimen, DVRD. For those of you who don't know, that's Dara, Velcade, Revlimid, and dexamethasone. And I had a stem cell transplant 4 months after I started induction therapy. I had the stem cell transplant in January of 2023. After my induction, I achieved a very good partial response. But after my transplant, I was MRD negative with stringent complete response. So that was great news. I'm still MRD negative almost 3 years out. I currently take 5 milligrams of Revlimid daily. That's down from 10 due to toxicity. I've been on 5 milligrams since February. And I have a Dara infusion once a month. So I worked in healthcare my entire career. My bachelor's degree is health information management. For a period of time, I was chairman of the board for the American Health Information Management Association. So I know my way around a medical record, and I know my way around codes, just enough to know that it's very complicated. And the people who do coding in the healthcare profession are typically certified, and many, over half, I would say, have 2-year associate degrees. So it's coding is very complicated. So, even though I spent my entire career in healthcare, it wasn't until my diagnosis that I truly understood the extent of treatment barriers and how critical self-advocacy is to improving access to needed care. So I'm talking, as Deanna said, about pre-authorization delays and denials, and I'm very honored to share my story in hopes that it might help some of you folks out there. So the next slide, and I'm not seeing this slide, so let me just try to, I'm not seeing, oh, there we go. So we probably should start out with a definition of pre-authorization. And, it's the process where a healthcare provider gets approval, prior approval from a patient's insurance company to proceed with a treatment, service, medication to ensure that it's medically necessary. And you'll also hear this referred to as prior authorization, prior approval, sometimes prior certification. That's more rare. But the provider is typically responsible for submitting this request, and it can be a lengthy process, as you'll hear with my story. And it requires details, a lot of details to support the necessity of the treatment. So the provider is providing a lot of information when they're submitting the request for pre-authorization. So, with healthcare costs rising, insurance companies are increasingly using pre-authorization as a tool to manage spending. According to the American Hospital Association, insurers often apply proprietary modifications to guidelines to create additional pre-authorization triggers and barriers, or denial opportunities. And we're seeing this more and more. I've had things denied this year with my primary care physician for things that, I've been, medications I've been taking for 20 years. All of a sudden, we need a pre-authorization to continue with that. So we're seeing more and more of this. As I mentioned at diagnosis, my myeloma specialist had prescribed DBRD. The team submitted the pre-authorization request to my commercial insurance company, and the DARA was denied. They were only going to cover the 3-drug regimen, VRD, without the DARA. Now, insurance companies have 14 days to decide whether they're going to approve or deny the request, unless the provider asks for an expedited review, and then it's typically within 72 hours they have to make a decision. Under federal law and most state laws, the insurance company is required to tell you, how they came about their decision. And even though they must submit that to the patient in writing, and that can be electronic, but most often you'll see that letter from your insurance company come through the mail that is communicating that the pre-authorization request was accepted or denied. And that, as you know, can take another week, week and a half. And if you're on vacation, it's even longer. So I received the denial notification a couple of days before my induction therapy with DVRD was about to begin. So the first thing I had to do was understand why the treatment was denied. Fortunately, also required by law is that written notice must include the specific reason for the denial, the plan, rule, or guideline used to deny it, and information on how to appeal. So in my case, I highlighted in yellow the reasons for denial from the denial letter. And there's a lot of information here. Number one, health plan criteria. The denial was based on health plan criteria. What health plan criteria? The specific criteria they used isn't mentioned at all in this denial letter. Darilex Faspro, which is the injection version of, or the subcutaneous version of Darilex, is not a covered benefit by your plan. So insurance companies have what are often called medical drug policies or injectable drug policies that specify which diagnosis codes qualify, what prior authorization must have been tried, dosing and combination requirements. All of that's going to be included in their drug policy. So I need to understand their drug policy for DARA. NCC guidelines, the next highlighted area here, National Comprehensive Cancer Network's NCC and guidelines, Category 1 treatment recommendation for multiple, let me back up. The NCC recommendations for DARA is that it has to be a Category 1 treatment recommendation. So I need to get my hands on these guidelines. to understand truly if DARA is a Category 1 treatment recommendation, and if not, what it is. Clinical documentation does not include a medical reason that meets health plan criteria. Okay, what clinical documentation didn't my physician send that the insurance company needs? Again, they're referring here to health plan criteria, which I don't have. And at the bottom, at least I have something to go on here. The source of the criteria that where they base their decision is their medical policy. And I won't read. There are two policies, pharmacy policies that the insurance company used to um, support the denial of the DARA. So I need to get my hands on these medical policies. So the first thing that I had to do it was probably the easiest, is confirm with my medical team what documentation did they send. And when a provider requests pre-authorization, there's a lot, again, that's required. It's a little bit of a process for the medical team, but also included in that is the specific clinical documentation that is required by the insurance company. And I confirm that my myeloma team sent all of the appropriate clinical documentation. I checked that the diagnosis codes were correct and that the clinical documentation included everything that my insurance company would need to approve the DARA. Being stage 3, high risk with amyloidosis, I had a lot of conviction that if I did not meet medical necessity to add DARA to the 3-drug regimen, nobody did. So everything was included that I felt was appropriate. Second, pretty easy as well. I needed to get my hands, like I said, on the NCC guidelines because they used these guidelines to deny DARA as well. It was denied for multiple reasons, as you could see. This was pretty simple as well. I just did a Google search. And the one thing I want to mention is these guidelines were written in 2022 that you're seeing up on the screen. So these NCC guidelines have been updated numerous times since 2022. So this take that with a grain of salt. These have been updated, so this is not applicable today. But I found the NCC guidelines for multiple myeloma, and these were never developed with the intent of defining payment policies. They're clinical guidelines, but the insurance companies are using the NCC guidelines as part of their criteria for approving or denying treatment. So I did a Google search. I got these guidelines, and I found in the guidelines that myeloma for multiple myeloma induction therapy, that DVRD was considered another recommended regimen. So that's good. Also, I found elsewhere in the clinical guidelines, because you see some of the treatments have category 1 next to them. There's the couple that have category 2B next to them. So I'm like, well, what does that mean? So the important point is that if I read in these guidelines that if a category was not listed next to the treatment medication combination here, it was considered a category 2A. So DBRD was considered category 2A because it's not a 1, it's not a category 1 or a 2B. So the default, everything else is 2A. But the denial letter had stated that it had to be, DBRD had to be a NCCN number 1 recommendation. So that was potentially going to be a problem. So the third slide, the next slide here, understanding treatment rationale. What was the insurance company thinking? I called the insurance company to understand the denial rationale. Specifically, I was looking for the items on this slide. So what clinical documentation didn't you receive that you expected to receive? And what would make a difference with the clinical documentation? What's missing? The second thing is, why isn't DARA considered a covered benefit? Third, what's the health plan criteria for DARA? Again, this is all from this denial letter. I'm trying to get information about it. And then, I need a copy of these policies. So customer support was very nice. I was calling every day, but they couldn't answer my questions. So they needed to refer me to somebody else within the insurance company who could answer my questions. Inevitably, this mystery person was in a meeting. They'll call you back. This was over a week where I am waiting for return phone calls. Customer support is confused every time I call them. And so I'm on hold a good hour every time I'm calling the insurance company. So this was taking me, a lot of time. So after a few days, I'm like, okay, this is enough. So I sent an email to the health plan insurance company CEO and waited a few days, didn't get a response. I'm still trying to call customer support. Fine. And then I said, okay, I'm going to send another email, and I'm also going to copy the CEO of the cancer hospital. So I did that, and miraculously, within 3 or 4 days, I received a call from the pharmacy lead at the insurance company, and she talked me through some of this stuff. The number one takeaway, and I was surprised that she even admitted this, is they denied DARA due to the cost. Secondly, they didn't even look at the clinical documentation. So she admitted this on the phone. She did reinforce that NCCN guidelines, it did need to be a Category 1 treatment, and that they would only approve Category 1 treatment recommendations. And again, DARA is a 2A recommendation. But she sent me the policies. Great. So I finally had those in my hand. And the first thing I see is that the requested therapy must be listed as an NCCN 1, 2A, or 2B recommendation. It's like, wait a minute, the denial letter says it needs to be a number 1 recommendation. The pharmacy lead just told me it needed to be a Category 1 recommendation, but their policy says 2A is also acceptable. So they have misapplied their policies. I also saw that Daralex Fast Pro, the subcutaneous version of Dara, wasn't in their formulary, their list of those drugs that they will cover, but daratumumab, the IV version, was. So I just told my medical team, I don't care how I get it, I just want it. So if it needs to be, the IV, fine. So let's change the pre-authorization request to DARA. Concurrently, while I'm working to try to get this information from the insurance company, my medical team is trying to schedule a peer-to-peer review, because in the denial letter, it states that, again, it's required by federal law. They have to tell you how to appeal. And for my insurance company, and I imagine the majority of them, that peer-to-peer review is next. So this took over a week for my medical team to get this set up. And I am calling the insurance company every day. Why isn't this getting set up? Finally, my physician was only able to talk to a pharmacy lead, I think it was the pharmacy director. So that is not peer-to-peer. A peer-to-peer would be a physician is talking to another physician. So, this was just another piece of information that we used when we, had to go further with this appeal. But we never did get a peer-to-peer review, and the pharmacy director again admitted to my physician that the DARA was denied due to cost, and 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 no other information. So within that same day, the decision came down that DARA, the denial was upheld. So, my physician tried. So the next slide is, so now we're denied again from the insurance company. Now it's time to go to external review. And again, that was stipulated in the denial. Here's the next step. So every state has their own entity where the external reviews are submitted. The insurance, and again, this is spelled out in the insurance company denial letter. In Utah, it is the Utah Insurance Department. So Utah is where I live. So it's the Utah Insurance Department. The typical information that the state insurance departments need is included on this list. And again, this is a quick Google search that I did before this presentation, but I'm like, okay, everything's online now. So this is what they need. So, and this wasn't my myelomas team first rodeo. I mean, they've done this external reviews a number of times, so they knew what to send. But I was driving this process because there's enough delays. I want my DARA approved. And so I wrote a letter defining where the insurance company misapplied their policies. Again, Category 2A, NCCN treatment guidelines should have been approved. We did not get a peer-to-peer review. My physician, my myeloma specialist, wrote a letter focusing on the clinical rationale around why he felt DARA was necessary. So I pulled all of the information together, submitted it electronically to the Utah Insurance Department, and I asked for expedited review. And again, I'm sure the myeloma team would have done this for me. They do it all the time, but I wanted to make sure it was done correctly, done quickly, and so I took the lead in it. Now the insurance department, the external insurance board or insurance department, has their own stipulated timelines as well. They had, I think, 7 days to render a decision, but the clock didn't start ticking until they started the review. So in my case, the Utah Insurance Department contracted out the review to an external independent physician. And I bet most of them do this. And he didn't receive the case to review for probably 3 or 4 days. So that's when the clock starts ticking. So in the meantime, I've been in contact with a point person in the Utah State Insurance Department. So once it was out of her inbox, she was a very good advocate for me to, I said this was an expedited review. We needed to get it done. And so I believe we received, even with her tracking it closely on her end, I think it took 72 hours, 3 days to get the decision. So the next slide. So the denial was overturned on external appeal. And this is not unusual. Over 50%, depending on the state, it can be much more, but over 50% of the denials are overturned on appeal. And the rationale for it being overturned was clinically it was necessary. And the reviewers reinforced that when you are buying insurance, you have an insurance policy, there is a expectation in that contract of services being performed, and they cannot just randomly deny the treatment. Also coming into this was the insurance company misapplying their policies. And basically the insurance company got a slap down from this external reviewer. So, and I should mention that I made the decision not to wait to get DARA. until this process ran its course, I was paying for it myself. I was paying $17,000 a week out of pocket. And I was the only self-pay patient at the cancer hospital, so they didn't really know what to do with me, but we figured it out, and I was paying a patient discounted rate of $17,000 a week. My myeloma specialist did not want me to pay. And so he was actually backing off on the treatment to just be the just the BRD, the 3-drug regimen. And I said, absolutely not. We agreed on a treatment plan. This is what we're going to do. And so part of the urgency I felt through this process was I wasn't sure I was going to get the money I had already paid refunded. So for me, every week was cha-ching, cha-ching, cha-ching. But once the appeal was overturned, once the denial was overturned, I was reimbursed by the hospital for all of the money that I had spent up to that point, and then the insurance company paid everything moving forward. So just summarizing the key steps here. Again, we're seeing insurance companies increase their denials of critical treatments. And when this happens, the best strategy for a patient is to become well-informed, persistent, and an organized advocate. And here are the steps to consider. One, you've got to understand the denial. And in my case, it was, it was pretty complicated. What medical policies are you referring to? What's the clinical criteria that you're basing this on? What are the drug policies? Why isn't this a covered benefit? Those are all things that I needed to understand. And that's where the research comes in, number two. It's so important if the insurance company is referring to a policy in their denial letter that you get your hands on this policy. And I stress to the insurance company, it's like, I'm a member and I'm paying a lot of money. I have a right to this information. Get the support of your medical team. You cannot do this alone. Actually, they take the lead in a lot of this stuff. I just wanted it not to be sitting on somebody's desk for 3 or 4 days or somebody's inbox for 3 or 4 days. So I became very good friends with the person at the hospital in charge of submitting these pre-authorizations. And I had to be the one asking for expedited review because I think the medical team, who are doing this day in and day out, they're just submitting it to the insurance company, and they're not necessarily asking for expedited review. So I was pretty focused after the first denial that took 2-3 weeks to get to me. I'm like, that's enough. We're asking for expedited review for the rest of this stuff. Number 4 is again, the provider does a lot of this, but file an internal appeal with the insurance company, and then, if needed, file an external review with the state insurance department or commissioner's office. Call and escalate, track delivery, receipt closely, be organized. Probably the one thing I would have done differently, but you don't know what you don't know. At the very beginning, when my myeloma specialist prescribed or made the decision on the treatment regimen of DVRD, I would ask, which I didn't, do you need to have pre-authorization for this? Yes, can you ask for an expedited review? And probably within the next day, I would have found out who on his team is responsible for doing that. I would have called the insurance company, a couple of days later to make sure they had gotten it, and that it was set up for an expedited review. And I would have tracked it much more closely at the beginning. I was shocked when I saw the denial letter 2 weeks, 3 weeks later, I think, by the time the mail delivery got it to me. So the earlier you can understand whether the insurance company is denying or approving your treatment, the better, and that you want to minimize those delays. So that is my story. Again, over 50% of the denials at the insurance company get overturned on appeal, and it's worth the effort. So thank you very much for your time.
Thank you so much, Anne. I loved your point about you don't know what you don't know. So I think that it's important to have these webinars so that we can hear from each other and learn from each other's experience. So thank you so much
Yeah,
for
thank
sharing.
you.
Diana, we did get one quick question. I'm wondering if we want to address it now or if we want to wait till the end, Diana.
We can address it now. That's fine.
Okay, perfect. So the question came in, it says, how much time do we have to do state review? I had a denial in January 2025. My two appeals failed and we paid out of pocket trying to see if we still have time to appeal to the state. We're in Pennsylvania.
That's interesting. You might want to check with the Pennsylvania Commissioner Board. They'll tell you, and you can look on any of those denials and find out what that deadline for you to submit additional paperwork. And then that would, if you got anything back from them, they'll tell you what that timeline is for them to get back with you. It's going to be based now basically on the last communication you've gotten from from your denial letter from your insurance company, and I would really check with that and check with your state to find out
Yeah,
what their timelines are.
right.
Usually, I think they're usually several weeks, maybe 4, 6, 60, 90 days generally is the turnaround period for reviews. Of course, it doesn't hurt to try to pursue it. I would never tell people to stop. You may be able to pursue it. Depends on who you're talking to on the phone on that particular day. Always, like Cindy said, keep records. Talk about who you discuss things with. If they say one thing, ask them to send a copy of what they say they're going to do or what they're not going to do. Keep a record on everything.
Perfect. Thank you so much. And go ahead and advance the slides again. Thank you, Anne. And we will do our Q&A with the group at the end. But now I'm going to turn the time over to Diana.
Thank you.
Diana,
So,
your camera's not on, just a heads up.
hello, everyone.
Thank you.
So, with the prior authorizations, I think really people really need to be understand just how complicated that process is and how you really need to advocate for yourself. And went above and beyond, making sure she was involved. If you don't have anyone, if you can't do it yourself, it's always to your advantage to have someone who can follow up on calls if you can't do it, because there's that time restraints and limitations. You have to get things done. I'm telling you, and if you don't file an appeal, it's not going to go anywhere. You have to file an appeal. You have to take that initiative and do those things yourself. Again, keep records. With Medicare Advantage plans, the prior authorizations are going up. The timelines seem to be getting longer because the doctors are getting overwhelmed. Providers are getting overwhelmed. If you know what your plan of treatment is now, again, I would encourage you to find out if you're in the line of treatment now. If you suspect you may end up in a different treatment later on down the road, you might want to start already getting your ducks in a row, especially if you're in Medicare Advantage plans. Now, if you have the option, and I would suggest everybody look at that, if you have the option to possibly get into a Medigap plan, you don't have all the prior authorizations as you would with a Medicare Advantage plans. Medicare Advantage plans are also, and it was announced today in KFF, that United Healthcare, Aetna, and some Humana, some of these big providers out there are trying to get rid of PPOs with the broader networks, right? They are looking at trying to get you in HMOs, smaller networks, and prior authorizations are going to go up. So if you have the option to get into a Medigap plans, doctors will even tell you if they know anything about insurance, that Medigap plans are probably your best option because you don't have all those prior authorizations for one. So please look at your plan documents for your insurance on their denials or what they're changing for the next year. It's going to be very important. Talk to your doctors, your providers, what your next line of treatment may be if you were to if you were to regress or come out of remission, so that you can already know what insurance plan you have are available to sign up for now, so you'll be prepared for next year. Please look at those plan documents. You have to look at those things. And even if you don't have haven't had a denial, ask for those plan documents anyway for your insurance, so you already have them ready. Okay, so we're going to talk about medical appeals as things that you can do to challenge and be successful at appealing denials. It's a big process, very familiar, similar to prior authorizations, um, but it's so important. Next slide. Here's the statistics of medical appeals. 80% of medical bills contain errors. 80%. Many of those errors are a result of incorrect billing codes used, duplicate or incorrect charges. And I'm telling you, when those errors occur, it's not because the bill is less, it's usually because the bill is high and you're paying a percentage of a bill that's incorrect. Don't pay your bill until you compare them to your EOB. I know a lot of people get a bill, they'll start paying it, especially if you've been hospitalized for any period of time. There are so many ways that bills could be incorrect, and the billing codes are huge. If you've ever looked at, and every time I do this, I'm thinking, okay, Diana, I remember seeing that bill for myself where you get X-rays or MRIs or something, and you may see three of this, you only had one X-ray done on this part of the shoulder or arm, and all of a sudden you see four of them. And like, they only had me on one position and one. Why are they showing four different X-rays? And they're charging you for each one of those. So I'm telling you, be aware of what's on your bill and get itemized billing so you can do a good comparison with your EOB. 57% of Americans receive unexpected bills with out-of-network charges at in-network facilities for non-urgent care. This this can be kind of confusing. If you've ever gone to a hospital, and that's a hospital where you may get your treatment, a lot of the providers there, the providers, maybe doctors or specialists, are not employed by that hospital. They may be employed by someone else, which means they are not in network, may not possibly in network, and they can charge you differently. So it is to your advantage to find out where those doctors, um, where they practice, what treatment is going to be in network, and the facility, what part of that facility is in network and what isn't. It's important to know that most emergency rooms are not in network. So be aware of those things so you can make arrangements and maybe find treatment or some of the outsourced treatment where you will be in network. Next slide. So there are steps involved with this too. Request an itemized bill and dispute inaccuracies. You might, if you've ever been to hospital for a period of time, you might see them coming in with carts and sending things, or maybe sending thing over to a side. There's a cost attached to that thing they send over to the side, just in case they may use it. And you may find it's already attached to your medical bill once you leave the place. But I was never under that heating blanket, or I was never under that cooling thing, or I was never on that. So they can't charge you something that was not used for you. So be aware of those weird charges and duplicate charges. Next slide. Also, ask for billing codes. Billing codes are important. Billing codes are going to determine what is going to be charged, if they can even charge it with that billing code, or if they're manipulate. I would say, I would like to say manipulating, but in a way, manipulating how the provider is going to be covered for certain things. I don't know if you've gone to the doctor recently and you're going to your primary care, and I'll ask, do you feel safe at home? Have some of these questions that's like, that's not, I've never asked that question. Now they can bill you for that. They're doing it's like a psychological profile thing on you. They can bill for some of those things. So be aware of what you're being billed for and that you're actually getting those services that they're saying they're providing. Next slide. Ask to see your contract. Anne said that. That's how important. You need to know what you're fighting. You need to know what they're saying they're going to charge or bill for and what they're going to cover. If you don't have a written agreement, you don't have the obligation to pay. So if you don't have a contract with the insurance company, which means you signed up for an insurance plan, or you don't have a contract through your employer for this kind of service through, I don't know, EOPs or whatever. If you don't have a written agreement, you don't have an obligation to pay. This is very important if you're getting calls from debt collectors insisting on you paying an unfair bill. And this is going to come into medical charges. You might get a third-party provider who's looking to collect medical bills, and they're saying there's an outstanding bill. And you're like, I don't remember that doctor. I have never heard of that doctor's name. You need to ask them to send you a contract saying that you actually had that service and this is provider. And you remember going to the hospital, you got to sign that little form now that says we're going to charge your insurance company. That's a contract. There's a contract, but you need to make sure the contract is actually your contract for that service. Demand they provide you with that contractual agreement showing your obligation to pay. Next slide. Number three, research the actual price of treatment posted by hospitals or providers. They are required, several years ago, they are required to have transparency on medical bills or treatments, and you can look that ahead of time if you anticipate some kind of treatment coming up. Hospitalpricingfiles.org provides an aggregated publicly available price transparency data from 6,000 plus hospitals. Your hospital should be able to tell you what they charge as well. And I would suggest you look at those before the treatment. Usually you've signed off and you're saying, I'm going to have this treatment and it's going to be in 2 or 3 weeks and you have to do all this stuff. That's your cue to start finding out what that's going to be charged. So when you get those bills in and then you get your UOB and you get your itemized bill, that is actually what you got. Make sure the price you were charged reflects your itemized bill and EOB. Do not pay until you reconciled everything. If you can't confirm that the price for your treatment is correct, call or write to your hospital and dispute the bill. Don't pay, dispute it. They can have it on record that you're disputing it, and they cannot require you to pay while something's in dispute. Next slide. Consider researching other local hospital prices and use that information to negotiate your bill. Hospitals want you to keep coming back to them because they want that revenue, especially if you're an insured person, because that helps offset some other patients may come in and cannot afford to pay. So get proof by taking pictures of their state or their stated prices. Compare prices at the Healthcare Blue Book, which is available to everybody, and it's online, and compare. There's a comparison tool for healthcare services, including imaging, elective surgeries, and more. The tool also ranks providers in a given geographical area in terms of quality and affordability. It's called, you go to healthcarebluebook.com. That's very important. If you have something and you're anticipating some kind of treatment, start getting that information online and start negotiating that bill ahead of time. Next slide. Address out-of-pocket services and refuse to pay for inappropriate care. So it's possible to receive out-of-network charges at a network facility that I mentioned earlier for non-urgent care. Challenge these costs with the service provider. Um, and make sure you look at, for instance, you may be in a hospital or maybe an emergency room and you have a doctor come in, and then you may have an intern come in, and then you may have somebody else come in, and they may be billing separately. So you may see different names on your bill. You don't have to, if you're in hospital anytime, if they say, well, we have interns or whatever here, you can say, I don't want them in the room. You have the right to have in that room who you want to be in that room. If you just want your doctor and a nurse, that's fine. You have the right to ask for that. Don't feel like you're pigeonholed into having all these other people in the room, or have this other person giving a second opinion, and you've already talked about that second opinion before to your doctor. Be aware of who's in the room because they're going to charge you accordingly. Same thing for surgeries. You don't necessarily, you can say, I want my doctor there who's necessary. You don't necessarily have to have all these other people in the room. Next slide. Call your insurance company. Anytime you get a new medical insurance plan, the first thing you should do is get a copy of their plan documents. You're going to have it in hand for when you're going to need it later on, because I guarantee you probably should need it later on. And then check your evidence of benefits, that's the EOB, to determine if the service or procedure is covered. If your insurer isn't covering something you think that should be covered based on that contract, like Ann was saying, contact the National Association of Insurance Commissioners. That is the state person you're going to talk to in case there's something that's not right. You can also contact your state and file an appeal. That will be the external appeal when you're contacting, going through the commissioners. That's your external appeal after you go through that internal appeal process. It's the same thing for prior authorizations as it is for medical bill appeals. Next slide. Call your employer's head of human resources department. Sometimes you can have them help you on this fight. You can ask your human resources department to advocate on your behalf. They have the plan documents. They know what they're paying for because they're paying a portion. Usually, if it's an employer for your insurance, they need to know what these plan documents say. And a lot of times, they may be able to provide additional assistance when you're filing those appeals. Next slide. Write to your hospital's leadership, just like Ann did. I mean, when she went to the CEO, I mean, people may find that intimidating, but you need to go to the people who are making the decisions. and who knows what's supposed to be going on. And that's what Ann did. If one of your other steps haven't worked and you still feel you're being charged for services that are not received or have been overcharged, write a letter or email the hospital CFO. You can also write to the hospital's board members through their offsite office and inform them of the hospital's predatory billing practices, because they don't want bad news out there, because they want people to keep coming, especially in light of a lot of things that are happening now. They need to keep a positive light on what they're doing, and they don't want things to be done, I would hope, don't want predatory billing practices to be done. They want to make sure their departments can be accountable and compliance can come in and say they're doing what they're supposed to be doing. So that is really huge. It may seem intimidating, but you're fighting for yourself and for what's fair. Next slide. Again, please don't assume you have to pay a bill that is incorrect, but you have to notify and start doing your due diligence to make this, to get the ball rolling, and notifying them that you are appealing a bill because this is incorrect. And you should not, they should put that bill on hold and not send it over to a collector because you're in the process of appealing something. You have the right to appeal through an internal and external process. You have the right to question the denial of a request for insurance to pay a bill. Always, you have the right to request that. Don't let the no the first time or even the second time deter you. Do what Ann did. Make sure you have read what's in that denial. Make sure you have itemized bill. Make sure you know your insurance plan. You know what the rules are regarding a Medicare or Medicare Advantage, what their actual plan rules are. NCC, what is that?
NCCN.
NCCN rules, because then you have the foundation for putting together a good appeal program. And again, your doctors, most doctors will be glad, either they can help file an appeal letter saying why there's a medical necessity to your treatment, and they can help that process as well. I would encourage you though, when you're doing this, only direct your information based on what the denial is. Don't start pulling in a lot of information that has nothing to do with your denial, because then it's something else for them to start looking at. Okay, so that is and it's been wonderful. I'm glad you brought this up, Anne, because I think this is invaluable, especially going in light now where there's going to be a lot of prior authorizations, and there's time limits on getting those prior authorizations done, and people need to be in treatment. A lot of people, I would say most people, don't have the advantage of having money sitting there where they can go in and pay for treatment that they really need while they're having this prior approval process going through. My husband and I had a lot of the same issue, and it's too late now for me. But he came out, and I didn't know until well after the fact that my husband was paying all these bills up to $3 million out of our own pocket for some of his care, and this is when he had insurance. So no one told me about the appeal process. I didn't know what my husband was doing with going through savings accounts and everything. So I would encourage you to start documenting, keeping a copy of your bill, looking at EOB, cross-checking, getting itemized bills, talking to your doctor about next treatments, especially when we're now in open enrollment, getting a copy of your plan documents, looking through your annual plan change documents that you have. And if you have an opportunity to talk to someone about in your state, some states, I think 13 states will allow you to go out of your Medicare Advantage to go into a Medigap plan without worrying about guarantee issue. So look at what your opportunities are for all of your insurance, what your opportunities were to change, or if you feel like you need to keep, look at your plan D. Make sure the medications you are on now will be covered, because you might want to do some comparison shopping on that as well. Things fall in and out of formularies all the time. And when she said they're denying based on cost, that is huge. Um, Part of the problem we're going to be facing all of you who are on Medicare Advantage are going to be choosing Medicare in 2028. Is part of the goal with them looking at Medicare Advantage and the cost and how much the government wants to pay toward Medicare bills and providers, is that in 2028, if you are going to be enrolling in Medicare for the first time, or if you're whether it's through age 65 or through disability in the 25th month, is that decision is going to be taken out of your hands. someone's going to be making that decision for your Medicare, and it's going to be an Advantage plan, and it's going to be based on cost, not based on where your providers are, not based on what your illness is. It's going to be based on cost, the cheapest available. So be aware of that. Start planning. Make sure you're aware of what insurances are available to you in your zip code. Don't necessarily go to a broker because a broker will generally only sell the products they have, and it makes them the more higher commissions. And with that being said, a lot of and it's going to be even more complex and challenging for you as a patient to choose your right plan or to change your plan because a lot of the agents are not being paid on renewals for Medicare Advantage plans. So there's a bigger opportunity for fraud, for things where they may change you out of a plan without you knowing it because they're going to a plan where they get paid for. It's a new plan, it's a new document. So be aware of practices that are not ethically or morally right. And if someone's calling you and telling you that this is what you need to do, buyer beware. I have even heard recently, and I almost dropped to the floor, that there are in some Medicare insurance plans are sending out urine specimen document cups to people to send in urine cups. Why? Why? They can't do that. This I said, are you sure that's not your doctor? You've already had a some kind of treatment or some kind of thing that's testing is supposed to be done. He said no, and I actually called the insurance company. He said, oh, we're beginning to do that. Well, that's not their role. That's not their role. So be aware of things that are being done incorrectly, please. That's my spiel. Questions, please. And Anne, feel free to answer these as well.
Okay.
Thank you so much. Like Diana said, this is your time to ask those questions. We've got questions that have been answered already. And we did have Anne replied back to one of the questions in the Q&A. So the question about Medicare Advantage plans denying more often than Medicare supplement plans. If that was your question, look for that answer in the Q&A. And then I'm just going to jump right into it. If you do have those questions, just type them into the Q&A. It's down at the bottom. If you're on the iPad or mobile device, you'll either tap the screen or the three dots and then Q&A. So first question is kind of about formulary. It's asking if there are specific myeloma drugs that are denied if a patient is on Medicare Part D.
Yes, there are, but you need to look at your plan. Last year, a lot of the Medicare Advantage plans dropped Revlimid as being approved, completely dropped off of their list, which means it's not formulary. And the expectation is, I believe the expectation is they knew in January that lenalidomide will be flooding the market more because they had those patents on it. So in anticipation of that drug coming to the market, now they can negotiate the price, hopefully because competition there is going to be down. We don't know. We'll have to wait and see. Because even when lenalidomide is out there, it still was only maybe $3,000 or $4,000 less than the Revlimid. So hoping now that that is going to be decreased, the cost of that's going to be quite a bit less. But be aware, please check your Plan D. Check your medications and make sure they are still going to be on formulary, especially those high price drugs. They don't, like Ann said, a lot of times they will deny things just because of price. And that's huge. That's price seems to be the term of the century now. It is like the biggest wedding ever seen. It's the price of a drug, not necessarily the necessity of the drug for the patient. So be aware of that.
Perfect. Thank you so much. I got a question. It looks like for Anne, how did you find the contact information of the CEO or leadership of the insurance company, hospital? How did you locate that information?
I had actually, well, I Googled the CEO of the cancer hospital, but I had worked professionally on a project with the CEO of the health plan a couple of years prior. Not that it mattered. I thought he was one of the good guys, but it was also available by just Googling the leadership of the health plan. That's how I got his email. I also would be given that information from the customer support person, just, who is the CEO. But, that's publicly available data.
Perfect. Thank
Yeah.
you so much. I don't think anybody would think to look for it unless there's that necessity. So it's good to know that it's available.
Well,
So
when you're paying $17,000 a week, it's like, but you know, I was surprised that I didn't get a response, but I did certainly when I included the CEO of the hospital. But yeah, I just Googled and got and I could even call I didn't, but you know, I was able to get their email addresses online as well. But I could have asked for that as well. Called
perfect.
the
Thank you
office,
so
yeah.
much. Got a question just about the slides. Yes, we will be emailing out a copy of the slides in our follow-up email, so be on the lookout for that. They've got some great resources. Got a question just about evaluating if the coding is submitted wrong. How would you look at that? Is there anything glaringly obvious, or is it a little bit
Yeah,
trickier sometimes?
I can take that. It's it's different if you're looking at this from a pre-authorization perspective because treatment hasn't been rendered, so there's not a claim that's been generated. So, but if it's denied after the fact, the billing department is not going to be able to do anything. Well, let me back up. How do you know if it's wrong? If you get the code, and you know there are different codes for inpatient and different codes for outpatient. So depending on what that is, you know, I just would Google, you know, this code and what it means, and you can determine yourself that, you know, is this in the ballpark? Because there's probably 5 different codes. I don't know offhand for multiple myeloma. So, you know, is this one of those 5? And if it's not, and you have a question about whether the coding is right, I guarantee you half the time at least it's because the clinical documentation is not right. Because the coder can only code what the doctor has written. And if the doctor hasn't written something, he or she can't make it up. So there is somebody at the who's got the rose pinned on them to do this coding. It's not the billing department, it's upstream from that. So it could be part of the physician's office. It could be a totally separate group of people. I know at University of Utah, they have a whole department, and it's probably 50 people who do this coding. And so they're the ones identifying based on the clinical documentation what to code, you know, because they're just turning that diagnosis or procedure code into a code for billing, and then they send it on to billing. So if you call the billing department and say, I don't think this code is right, they're going to just push you off to another person. So I would always start with the physician if you feel that or the physician's team, if you feel that, well, you've Googled, you know, here's this 1, 2, 3, 4, 5 code. It doesn't sound like it has anything to do with what I was treated for. And so, or the medication that they're prescribing, or the, you know, the treatment that I'm going to get, this is totally off the wall, or is it pretty close? So you can make those determinations as a lay person, but if there is a concern whether it was not, if it's not correct, then, I would go to the billing, I would go to the physician's office. Same thing too with the prior authorization. Those people doing the coding for the prior authorizations really aren't as trained on coding as some of the other, you know, when it's going to billing. They're not as necessarily received as much training. But again, you can just Google the code, going, okay, this does not look right. Let me call the doctor's office, because the billing department's not going to change anything unless the doctor's office or the medical team tells them to change something. So,
Perfect.
yeah.
Awesome. Thank you so much. That's good.
Google is your friend.
That's perfect. Thank you. All right. Next, we've got just a couple questions about deciding which type of plan is best for you. So, is a straight Medicare plan the best, or Medicare Advantage plan? And how would somebody go about making that decision?
Well, first of all, find out gotta look at your treatment, what you're gonna be treated for, right? I would tell you that if you are a cancer patient, or have any other comorbidities that are expensive, diabetes and all these things, then and if you're on Medicare, don't just look at traditional Medicare. You need to have something to cover that, because if you're a traditional Medicare A and B only, then 20% of the bill, 20% is going to be yours to pay out of pocket. And if you go to the hospital or anything, and it's a $1 million bill, $200,000, you're going to be responsible for. I think you really need to look at getting and I don't want to, well, I do kind of. Look at your Medicare options, Medicare Advantage options, Medigap plan. And when you're looking at Medicare options, Medicare Advantage, do not be sold on just your vision and your dental. Because when have an illness that's very expensive, like cancer long term, then that vision dental is expensive, is important, but it's not as expensive as the real care that you need, and that's your medical treatment. So don't be sold just on those things. And unfortunately, those unfair practices have been happening. Talk to SHIP, State Health Insurance Program in your state. They can or go to cms.org. You will find every single plan available to you, whether it's Medicare or Medicare Advantage. And you can do those comparisons, and you're going to need to know what your treatment is, and that includes all your medications, oral or induction, all of those things. And that way you can do comparisons as to what best insurance plan is for you. If you're on ACA, Affordable Care Act on exchange, you generally have until December 15th to sign up for your plan. It's already started November 1st to be effective for for January 1st. But some states give you longer, maybe February 15th, or sometime maybe even longer for you to sign up for ACA. You should be getting bills in, and I know it's kind of confusing for a lot of people. Should I sign up for ACA? Because I don't know what it's going to be. I don't know if those subsidies are going away or not, because that is why we are on a shutdown, because trying to keep those subsidies in place. That's one of the primary reasons that we know of, right? Is trying to keep those subsidies in place so people can continue to be covered. So it's hard to decide what to do now based on what's going to happen next year. It's going to be effective January 1st, but you can't go without insurance. So those things are going to be decided somewhere, hopefully soon. Um, and just the premiums alone without the subsidies are going up about 27% or higher. So you already know that what you've been paying could possibly be 27, 30% or more higher. And if the subsidies go away, it could be 2, 3, 400% higher than what you're paying now. So if you have a spouse who has insurance, maybe consider looking at other options for insurance. It may be cheaper to be on a spouse's insurance than your own through ACA, and if you have the option to be on a private plan and keep Medicare A and B as a backup. I mean, it's you got to look at everything. And again, talk to somebody at State Health Insurance Program or CMS.org so you can get some good comparisons out there.
Perfect. Thank you so much. We are just over time, barely, but wondering, we've got just a few more questions. Diana and Anne, are you
Yeah, I'll
able to
make them
stay for
quick.
just a few more? Okay.
Yeah.
So next question is just if you can clarify what a contract is. Is it just my insurance contract, or could it also be when a new treatment is to begin?
Both. It could be both. Because when you're signing off on getting treatment, when you go in that day for that treatment, or you're signing off on what, so we can bill for this treatment as a contract. You're signing that you're going to pay for this treatment you're about to get. When you sign up for an insurance plan, you have to sign that you're accepting that insurance plan agreement with them. That is a contract. You have a contract with the insurance company, and insurance company has a contract with you that you will get the treatment that you're paying for. Again, that you're paying for. That's why you need to go back and make sure they are giving you the treatment that you're paying for. That is part of the appeal and understanding what your plan is. So that is a contract.
Perfect. Thank you so much. One more question just about appealing an actual policy. It says, what is the best way to appeal an actual policy with an insurance company? In my case, getting them to consider the most recent data concerning a particular treatment. Currently, they are classing it as experimental when the treatment is FDA approved.
A couple of things that I can add here, because this happened to me with DARA and maintenance. It was not FDA approved as a maintenance treatment at the time. And my physician, what was important was that he needed to appeal this decision based on medical necessity. And I know in the Medicare guidelines, Medicare won't, and I'm doing this from memory from a couple of years ago, they won't approve an FDA, a drug that's not FDA approved unless the physician can document the medical necessity of providing this treatment. So going after it from a medical necessity standpoint, which would require your provider to be involved, would be the way I think to go on this. That's the way I went with my doctor on it, and it got approved.
Perfect. Thank you so much. So leaning on those people who are there to help you, really important, making sure you get in contact with your medical team. So thank you so much. Got one last comment just about grants. Looks like someone in the comments said they received a grant for the drug deductible, $2,000 from HealthWell to cover the deductible for 1 year, and they got $8,000. So just be aware there are grants out there to help with this. And that actually will take us to our next slide, because it is about our Connect group. So if you're not aware or not signed up, we do have financial Connect groups. Diana and our financial coaches are in there answering questions. I know everybody keeps track of when those grants do become available. So please consider signing up. You can scan the QR code, or we'll also put it in the follow-up email.
And I would like to include in this, I also, in that Connect group, financial Connect group, keep you aware of things that are happening that you need to be aware of, that to help mitigate your costs or mitigate challenges you may face. I decipher all that information and I put it out there. It's very timely.
Very nice. Thank you. The other plug I'm going to put in as well is it's a nice way to connect with people and not be a part of social media, which can be really kind of trying depending on what's going on. So I think it's nice to kind of step away from that and just be focused in on what you want to hear. So again, just want to thank you, Diana and Anne, for the wonderful presentation. We got several comments as well, just thanking you for your time. So thank you, and we'll go ahead and close out the session.
Bye, everyone.
Bye-bye.
Thank you. All right. As a reminder, you will have the opportunity to participate in a quick survey. We hope that you'll take the 2 to 3 minutes to fill out the survey, just to let us know how we're doing, what we can do for future topics. I've got a few of our upcoming events on the slide. We've got Thursday, November 6th at 5 p.m. Information about when to start CLL treatment. Thursday the 13th, our Spanish myeloma community will meet to discuss what should I eat if I have multiple myeloma, benefits of diet and physical activity. Sounds like a wonderful program. And then on Friday, the 14th of November at 4 p.m., we've got a all blood cancer event about journaling to build resilience for patients and caregivers. So we hope that you guys will consider joining us for those different events. We'd like to again thank our sponsors, Pfizer, Adaptive, Cura, Johnson & Johnson, GSK, AbbVie, Amgen, and Taiho. And lastly, just want to thank you guys again for joining us today. I've got my email up on the slide. Love to hear from you. Please reach out if I can help, or if you just want to connect.